Uh, Baby Mobashira Mariam, who is a 1 year, 10-month-old child, resident of Bangladesh, informant being mother and is reliable. Mother got the baby with complaints of recurrent respiratory tract infection since 3 months of age. According to the baby was apparently asymptomatic and was feeding normally till the age of 2 months. Since then, she noticed baby having forehead sweating while feeding. And she also complains that baby started having recurrent respiratory tract infections and stridor since 2 months of age, once in every 20 days to 1 month, and was acquiring treatment from local hospitals and clinics, not requiring hospital admissions. Also gives a history of poor weight gain till 3 months of age. Later on, she gained weight appropriately. As the symptoms persisted, they got the baby evaluated in a higher center around 9 months of age, where she was diagnosed with a heart disease, a hole in the heart, for which she was advised surgery. As they were not financially stable, she got to decided surgery later. They were on medical management since then. In this period, the baby continued to have recurrent respiratory tract infections around 3 to 4 times and with persistent stridor. The stridor is more while sleeping and while feeding and it is of inspiratory type. So, they came here for further management, that is surgery. There's no history of Saccharus cycle. There's no history of cyanosis or cyanotic spells. There's no history of LOC, fatigue, thromboembolic episodes. Antenatal history. She was born out of a non-consanguineous marriage. She's a fourth order child. All 3 trimesters of pregnancy are uneventful. There's no history of fever with rash or gestational diabetes or hypertension during the antenatal period. Natal and postnatal history. The baby was born out of LSCS. The mother is an elderly gravid of 39 years. She's a full-term baby, cried immediately after birth with a birth weight of 2.7 kgs, needing no NICU or PICU admissions. Immunization was up to date as per national immunization schedule, and the developmental delay is present. Diet history: baby is still breastfeeding with soft diet intermittent. Family history: there's no significant family history. Treatment history: the baby is on syrup furosemide 0.4 ml BD, syrup ketotifen, tab enalapril 5 mg, and tab ecosprin 25 mg since 9 months of age.
So,
Summary one.
Go ahead.
A 1 year, 10-month-old baby born out of non-consanguineous marriage to an elderly gravida mother was found to have recurrent respiratory tract infections, stridor, forehead sweating since 2 months of age, with no history of cyanosis or Saccharus cycle, and was diagnosed as syndromic baby with congenital heart disease at 9 months of age. It's most likely to be a case of Down syndrome with acyanotic congenital heart disease with moderate to large left to right shunt.
How can you make out Down syndrome from the history?
Uh, on observing the baby.
That comes later, probably. One thing, like Jairaj sir said last time, when she's the fourth child, right?
Yes, sir.
So you should see whether there were any other cardiac anomalies in the other siblings.
No, sir. All the other siblings are fine,
Yeah,
sir.
we discussed this last time. If one sibling is having a cardiac surgery, cardiac problem, what is the incidence of cardiac problems in the other siblings? So I hope you remember what we said last time.
Yes, sir.
So
There are
if
no
if it
other
is
siblings
if
is
it is
not.
a single child, it's all right. But when there are multiple siblings, then you must bring out that history that all the other siblings are normal.
Okay, sir.
Okay.
Yes, sir.
So in this history, you think that this is a left to right shunt, huh?
Yes, sir.
Well, because of repeated respiratory infection.
Yes,
What do you
that
think the cause of stridor would be?
Strider, as the baby was probably as looking, she was looking of a Down syndrome baby, sir. The tongue was large and it was protruding out. So maybe while lying down and while feeding, the tongue might be falling back, and that would be the reason for inspiratory stridor.
Yeah, possible. Any other reason?
And short neck also, sir.
Any other reason?
Any, it could be syndromic babies would have tracheomalacia or laryngomalacia.
No, with a left to right shunt, she may be developing pulmonary hypertension. The pulmonary artery may be enlarged. and that could be causing compressing the bronchus. That is also one of the possibilities. Okay, all these things should go through your mind, and when you're examining the patient, you should look for all these things.
Yes, sir.
Okay, go ahead.
General examination, the baby is conscious, cooperative, and was playing comfortably. The baby was examined after taking consent from the mother. The baby is thin built and nourished, height of 75 centimeters, of weight of 7 kgs, BMR 12.4 kg per meter square. There's no pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy. Head to toe examination, there's upward slanting of eyes, flat nasal bridge, small ears, palmar simian crease was present. There's decreased muscle tone while walking, and the widely spaced torso. Vitals pulse is 110 per minute, regular, sinus rhythm, no radioradial or radiofemoral delay. BP of 96 by 54 mm of Hg measured in supine lying down posture in left leg. No variation in BP in the other limbs. Respiratory rate of 26 chest rates per minute. Saturations of 97% room air. Temperature of 97 degrees Fahrenheit and JVP is not elevated. CVS inspection. Chest is bilaterally symmetrical. Trachea appears to be in midline. Apical impulse is seen over the left anterolateral chest. No visible pulsations or scars, no chest wall deformities, and no engorged wounds. On palpation, trachea is in midline. Apex beat is diffuse, hyperdynamic, felt over left 4th to 6th intercostal space up to mid-axillary line. There's a palpable P2 and no palpable thrill or parasternal heat. On percussion, the left heart border corresponds to the apex, the right heart corresponds to the sternal notch. On
No,
auscultation,
no. Hold on. That percussion, go back to your previous slide.
yes,
Percussion, left heart border corresponds to apex and right heart border corresponds to sternal margin does not mean anything to anybody. Whether the percussion is done, whether for evidence of cardiomegaly. So you have to say whether the left heart border is outside the midclavicular line. So you go one space above the apex and then come from lateral to medial and see whether it is medial to the midclavicular line or lateral to the midclavicular line. Similarly, on the right side, you percuss for the liver dullness, go one space above and come from lateral to medial and see how far from the sternum it is. So this is how you have to mention the percussion. Percussion, if you mention, when then you say whether or there is evidence of cardiomegaly or no cardiomegaly.
yes, sir. In this apex
What
beat is
do you mean by
almost in the mid.
palpable thrill? What exactly do you mean by palpable thrill? Is there any other thrill? Thrill is felt on palpation only. Otherwise, the thrill is enjoyment or happy. So don't duplicate it by saying palpable thrill. Is a thrill present or not? Because it's always a sign on palpation,
Sorry.
No.
Okay.
S1 is normal, sir. S2 is single P2 loud. No systolic or diastolic murmurs heard. Other systems respiratory bilaterally equal vesicular breath sounds present and stridor was present. On parabdomen, soft, non-tender, no organomegaly. CNS, no focal neurological deficits.
No systolic or diastolic murmur.
Yes, sir.
And why would you have a loud P2? And where is the shunt?
I couldn't hear any murmurs, sir.
Okay, how do you explain that? Your diagnosis was a left to right shunt. How do you explain that?
There could be a large shunt, sir. So there might be there must be low velocity flow across the shunt. That might be a reason for the decreased murmur. No resistance to the flow, basically.
You mean she has a
Or
single ventricle?
the equalization of pressures might also be a reason.
That generally doesn't happen with just an isolated VSD or an ASD. Okay.
It's a large site. Usually they produce a ejection systolic murmur because if there's a large shunt, the output from the right heart is always very high, So that means the pulmonary valve is relatively narrow. So the most common finding. Large VSD, the VSD does not produce any murmur, but they may have a ejection systolic murmur because of the outflow to the pulmonary valve. So
Yes,
this
sir.
one, you think it's a small VSD, a moderate size VSD, or large VSD?
This it is a I think it is a large VSD, sir, because in case of a small VSD, there will be restriction to the flow across the shunt, so there will be a louder, harsher murmur which could be heard on auscultation. In the same way as in a moderate VSD as well. In generally in a large VSD, when as there is no resistance to the flow, there wouldn't be any murmur, or in case of an equalization of pressures. But there should be an ESM in the pulmonary area, ejection systolic murmur, but there was no murmur, sir.
A large VSD present. What's the presentation of a large left-right shunt at the ventricular level?
In a large left to right shunt, there is increased pulmonary blood flow, sir.
No, I
So
said,
generally
how do
within
they, I asked, how do they present? What are the presenting symptoms? I'm fed up of this forehead sweating, forehead sweating, forehead sweating. That means
usually
something in a baby. There, if you look into pediatrics, there are 100 reasons for a forehead sweating. So you must answer me, what are the symptoms, presenting symptoms of a kid with a VSD with a very large electrolyte?
Sir, usually in a large VSD, usually presents within 6 to 8 weeks of age, sir. With most sometimes they present with features of congestive cardiac failure, sir, or they present with feeding difficulties while
Yeah,
and chakras.
that's how they present. Feeding difficulty. What exactly the most common presentation is? They come with tachypnea, tachycardia, and feeding difficulties, and failure to thrive. These are the usual symptoms for not forehead sweating, and means nothing to me actually. Forehead sweat. Everybody goes on saying forehead. What do you mean by feeding difficulties?
Feeding difficulty while there will be usually a suck cycle, sir. Baby will because of
Why is this suck cycle?
because of increased pulmonary blood flow, there is decreased and there is edema along the basement membrane. There is decreased oxygenation, oxygen diffusion capacity across the basement membrane.
That's not correct. It's because of the left ventricular failure. That's the most common presentation of left ventricular failure because the efforts required to suck. So the mother complains that the kids try to suck, then becomes tired, stops sucking, then again after some time. And also it takes much longer time to feed compared to normal. And that's why the feeding difficulty is equal to suck rest suck cycle. So that's one thing. The other thing is failure to thrive. These are the usual symptoms of a large left to right shunt. What do you mean by failure to thrive?
Failure to thrive is the baby will have a poor weight gain, sir, which is less than 15 percentile, 5 percentile of the normal weight gain because of poor feeding. Because of poor feeding due to
Yeah,
LV failure, the baby will have
good.
poor weight gain.
It's not only poor feeding because of the cardiac output is also low.
Is also there. Yes, sir.
Okay. So there are two aspects in that. One, weight gain. Two, I told you last time, in an infant user length, in a child, you say the height, So these are the two factors,
Yes.
the height and the weight. And usually in most of the states, the weight is more affected than the height actually, or the length of the baby. So these are the percentages. Don't say forehead setting, forehead setting. It means nothing actually. So, and what time you said they present very large VSD? After 6 months, is
Six
it?
to 6 to 8 weeks, sir.
Yeah. What?
But after 4 weeks, generally there is decrease in the peripheral pulmonary vascular resistance, sir. Because of that, there is increased sudden pulmonary blood flow, which makes
Yeah,
the baby difficult.
yeah. Because the normal reduction of the pulmonary vascular resistance of the newborn is regresses by about 6 to 8 weeks, and usually that's present at that time. All right. How do you know
Okay.
large VSD or small VSD? This I've told you
Uh,
many times.
yes, sir. In case of a small VSD, generally the presentation will be at a later stage, and there will be
You know,
the baby will
on examination, we want to
on
know whether
exam.
the shunt is more than 2:1.
Yes, sir. When there is a loud murmur, there is a murmur, sir, a loud murmur across the loud murmur we can hear in the left parasternal region in case of a small VSD. Whereas the if it is a loud P2, that indicates generally the shunt across
You
the
should,
shunt is
you should have answered in a VSD. It's a mid-diastolic murmur in the apex of the mitral area. In ASD, it's a mid-diastolic murmur in the tricuspid area because that's a flow murmur.
yes, sir.
The ejection systolic murmur is a flow murmur across the pulmonary valve or the artery outflow tract. So when there is a mid-diastolic murmur in the apex, you know that usually the shunt is more than 2:1.
Yes,
But
sir. Yes.
we have asked you many times, how do you define the small, medium, and the large VSD? I'm sure we explained it many times. You should be thorough with those things, the measurements. And then the other thing they ask you, uh, what the incidence of the VSD and what's the natural history of a VSD?
In incidence of VSD, it is almost 8 to 10% of all the congenital, most common type of
No, no, no,
congenital heart disease.
that's not correct. The answer should be
30%.
isolated VSD is one of the most common congenital heart defect. Probably only a bicuspid aortic valve is more common. And usually the incidence is at 25%. Some people say 20 to 30%, but roughly 25% isolated VSD. Then the VSD may be a part of a other congenital heart disease. Like what?
It could be a part of tetralogy of Fallot. It could be a part
Very
of
good. Very good.
it could be a part of basically TOF physiology
Huh?
or AV canal defect.
Yeah.
It is associated with PDA, coarctation of aorta.
When you said TOF, you should go around and saying DORV says the same this thing,
Yeah.
and then AV canal defect. So all this comes in this one go.
It's obligatory in some of the congenital heart disease. A truncus should always have a VSD. Otherwise, they will not survive. But tetralogy of Fallot, VSD is one of the always present in VSD. In some case of transposition of the great arteries, simple transposition, maybe only ASD or PFO present. But in other, a VSD is always present, plus or minus permanent. Many cases of tricuspid atresia, an ASD is absolutely must for such. Many of them may be associated with VSD and pulmonary stenosis. So these are the things which come in the pathology physiology, where there's a reduced pulmonary pressure. So isolated VSD, say 25%. Some people say 20 to 30%. But we stick to, don't say 10% VSD. The presence of VSD is much more. And but a natural history of VSD.
Natural history, usually 60% of the muscular VSD is usually close by
Now, that's
uh,
natural history.
usually, usually a patient presenting with intractable congestive cardiac failure should be treated within 1 year of age. And spontaneous closure
That,
usually happens
that's
in
not that's not very natural history.
spontaneous closure.
Large VSD untreated, only 90% of them survive or reach 1 year. In other words, VSD untreated, large VSD untreated, 10% of them die in the first year. But very complicated congenital heart diseases, 90% of them die in the first year if not treated. That's a natural history. And the other natural history, what is the spontaneous closure of VSD? So these are the things you are expected to answer when somebody asks you, what's a natural history? What's your idea about the spontaneous closure?
Spontaneous closure of VSDs occur in muscular VSDs and some of few perimembranous VSDs. In muscular VSDs, usually 30% of the closures occur by first 6 months of life. Or sometimes you can wait up to, or it can occur up to 8 years of age, but not more than 8 years of age. We wait for its closure. Whereas in our perimembranous VSD, 60% of the VSDs are closed, but by more than 5 years of age, we shouldn't wait for the closure of perimembranous VSD. And if the VSD is of more than 8 large VSD, we usually treat when it is diagnosed within 1 to 2 years of
8 mm is not in VSD. That we usually say ASD. VSD, you always go by the comparative size of the, because in the
aortic
child,
aneurysm.
2 kilograms of the aortic annulus. That's how we compare it, not 3 millimeter, 5 millimeter. The answer should be taken all VSDs, 30 to 40% of the VSDs closed. Very large VSDs will not close, but 50% of them will become small. And there are some VSDs which close, some VSDs don't. And also nowadays, because we do echocardiography regularly, if you see a VSD, a small size VSD, newborns, 80% of them will close. This is what's given in your recommendations of cardiac surgeons, cardiologists. And if you see a small VSD at the age of 3 months, 50% of them will close. And if you see a small VSD at the age of 1 year, 25% of them will close. So that is one. And then the other question is, which VSDs will close, which VSDs will never close?
Perimembranous and vascular VSDs may close, whereas the malaligned
You say the other way. Most commonly, muscular VSD, especially the mid-muscular VSD or anterior part of the muscular system, they close maximum. How do they close?
due to systolic contraction, there is
Systolic contraction. That doesn't make any difference.
Why are you bringing my
overgrowth of
confusion here? Small muscular VSDs as a child grows and when the heart improves, muscle fibers also are hypertrophied, and then they close the VSD. It's simple.
Because you see the right ventricle from the right side, so trabeculated, and then they actually that's why a VSD present from the left aspect of the ventricular septum may be single. There is maybe multiple. So the growth of the muscle, the muscle, interventricular muscular septum, hypertrophy of the trabeculae, that goes. And what about the next common is the perimembranous.
Yes, sir. Perimembranous, it is either by closure of the overgrowth of tissue from the adjacent, or it is by septal leaflet of the tricuspid valve, or by Venturi effect, the aortic right coronary cusp or the non-coronary cusp of the aortic valve, or there might be septal interventricular septal aneurysm.
It's a membrane. You should be clear in each word you speak. Right? Aneurysm of the membranous septum, that comes in the second. The most common is the septal leaflet of the tricuspid valve comes attached the margin to the VSD. And also the chordae of the septal leaflet, they fuse together so much so that partly closes the VSD. Attachment of the septal leaflet to the lower part of the VSD margin that closes. Then aneurysm receptor of the membranous septum. Then some texts will say endocarditis and which details that I don't know. These are the common causes. And suppose a septal leaflet comes attached to the lower part of the VSD margin, what's the effect of that? And it's gone.
Sir, I will make it.
Have you heard of Garbody defect? What is Garbody?
Yes, the body defect is shunt between the left ventricle to the right atrium. So, it is due to defect in the endocardial cushions. Endocardial during the development of the AV cushions, during the fusion of the interventricular septum between the right atrium, interatrial septum and the interventricular septum. Uh, there is a gap between because the AV cushions which are there, which is anteriorly and anterior part of the AV cushion and posterior part, there is a malalignment in the.
You're going round and round without saying.
Simple way is to say that the tricuspid valve is at a lower proportion than the mitral valve.
Yeah, the mitral anti-leaflet is attached to the ventricular septum at a higher level than the septal leaflet, so much so that small area, which is known as the atrioventricular septum, it comes in, the right atrium comes directly in contact with the left ventricle. Because these days, when you do an echo, you can always see the attachment of the septal leaflet of the tricuspid valve at a lower level of the anti-leaflet of the mitral valve at a higher level. That area, if they say, oh, that causes a Garbody defect. Similarly, if there's a VSD and the septal leaflet comes attached to it, almost produces the same effect. That means you can directly shunt from the left ventricle to the right atrium. Okay. These are the basic things everybody has, and you were giving a roundabout explanation, but that should be specific. Okay.
1-year-old baby of Down syndrome with acyanotic congenital heart disease with large left to right shunt at post tricuspid valve level, most likely a VSD with pulmonary artery hypertension with no features of congestive cardiac failure, thromboembolic episodes, or infective endocarditis.
What are the other congenital cardiac anomalies associated with Down syndrome?
Coarctation of aorta. There could be AV cushion, AV canal defects.
AV canal. That should be the first answer. AV canal defect.
AV canal defect.
AV canal type of VSD. What's a canal type of VSD? What do you mean by canal type of VSD? It's
That's what
defined as a posterior inlet paratricuspid defect. It's posteriorly, it's near the leaflet, the tricuspid valve, paratricuspid, and it's at the inlet of the right ventricle. And there's a VSD outlet. What is that?
Symbiotic VSD.
Huh?
Symbiotic VSD, sir, or doubly
No,
connected
no.
VSD.
Outlet is not symbiotic. It's not. Because LV outlet is
Infundibular.
when you say outlet defect, it's the infundibular area.
Infundibular VSD.
Defect infundibulum or subpulmonic VSD. So that's another thing. VSD is maximum closer in muscular defect. Second is perimembranous. Almost never closes in a canal type of VSD, and never closes in what type of VSD? It never close.
Malaline VSD.
Yeah, line, like a tetralogy. In fact, as the child grows, it becomes bigger and bigger. And the infundibular sector or subpulmonic also usually never closes. Okay. These are
Remember,
basic.
the classification of VSDs is with the ventricular septum from the right side, the right ventricular septum. So all these positions are classified according to the position on the ventricular septum as seen from the right side. So Van Praag's classification and the other.
Yes.
So that is why it is called inlet, outlet, and muscular and perimembranous.
What's the percentage? I'm sure you know. Incidence of VSD according to the site. You would say
72.
yeah,
Most commonly 70 to 80% is perimembranous VSDs. 5 to 20% is muscular VSDs. Whereas 5 to 7% is inlet VSDs and 5 to 8% is outlet VSDs.
maybe the canal type of VSD may be less 2 to 3%. And I told you many times the outlet VSD in Western literature is given as 5%. The Asian type it's about 30%.
30%.
That's why that. Even the Asian type of tetralogy is like that. Tetralogy is membranous VSD extending into the muscular septum or extending into the subpulmonic area or extended paratricuspid. So in the Asian type of tetralogy also it's a symbiotic plus subpulmonary. That's very high in Asia. Okay. No endocarditis episodes of infective endocarditis.
So what do you want to do?
Sir, I would further like to investigate the baby with X-ray, chest X-ray, ECG, and an echocardiogram to further prove the diagnosis.
Are you doubtful about your diagnosis?
Because there is a no murmur, it could be a tricuspid level shunt could be anything. So because of there is only PAH and a hyperdynamic apex which I could feel.
Okay, that is one good thing. Good. And the second thing is you always, in any case, you have to see for associated other defects.
Yes, sir.
That is why you have to investigate and make sure that there are no other defects. Okay.
What are the associated defects?
Associated defects, it is PDS associated at around
Yeah, very good.
30%.
Very good.
Coarctation of aorta in around 10% of cases. There could be a subaortic membrane or an associated infundibular stenosis. Uh, and there could be a
Sometimes
bicuspid aortic
left
valve.
superior vena cava. Sometimes VSD may be associated with ASD. Left
Mitral
superior
valve.
vena cava is usually present in about 8 to 10% of the. So these are the common associates. PDA, coarctation, SAM, subaortic membrane, left superior vena cava, and sometimes both ASD and VSD. Okay.
Okay. Tell us the investigation.
Yeah.
Slightly overexposed chest X-ray, well centralized, with trachea in the midline, with a CT ratio of 0.41, with RB type of apex, with left pulmonary base full, with right heart border enlarged, splaying of carina is present, sir, with prominent pulmonary plethora, with normal CP angles and no other bony deformities.
In a
What?
VSD, do you get a right ventricular or a left ventricular apex?
If it is an early stage, usually in a short or moderate VSD, in the early stages, there is a left ventricular hypertrophy, sir. As the pulmonary hypertension sets in, there is a right ventricular hypertrophy, sir.
No, there will be biventricular hypertrophy, not only right ventricular hypertrophy. So when
Yes,
you
sir.
comment on the apex, be careful because this is a deep inspiratory film.
Yeah,
Both,
that's why it looks like.
both the diaphragms are low, very low. So sometimes it is difficult to comment on the apex in an X-ray like this. And if it doesn't fit your diagnosis, you have to tell them, sir, this is a deep inspiratory film,
That's why
right?
it's not a heavy type of
Yes, sir.
airplane. That's the reason why it's.
So usually VSD will give you an LV apex or a biventricular apex. Okay. Is the aorta small or large here?
Aorta looks small only, sir.
So is it
The
intracardiac,
prominence of aorta.
extracardiac?
It is intracardiac only, sir.
Yeah. So these are the things that you should say. You talk about the lung fields, bronchovascular markings, the ventricular pattern, and then the aorta. So it will tell you whether it's intracardiac, extracardiac, whether it is AST or VSD, how much is the shunt, and also in an older child, you must also see whether there is evidence of pulmonary arterial hypertension. How do you look for pulmonary arterial hypertension on an X-ray?
There would be peripheral pruning, sir.
That is late stage. Before that,
Right ventricular hypertrophy.
the central pulmonary artery will be enlarged and there will be multiple, more than 6 end-on views of the pulmonary artery, which looks like nodules, thick nodules. So if you see more than 6 end-on views, then that shows that there is some amount of pulmonary artery hypertension. When the pulmonary artery hypertension goes much more and then almost on the verge of becoming isomerization, then you will have peripheral pruning. Okay, these are the things when you see an X-ray, these are the things to look for, especially in a VSD. Okay, what else? What do you expect in the ECG?
So this is ECG doesn't have a precordial lead, sir. So I took a ECG from outside, which is done 6 months earlier to the present current ECG.
Sorry, didn't get you. I didn't hear what you
The
said.
current ECG in our hospital doesn't have a precordial lead, sir. So so I took an ECG from outside hospital where they were evaluated 6 months earlier, sir.
Okay, read it. Why they didn't do precordial leads in our hospital?
Usually they don't sedate and do the precordial leads.
Usually,
Usually they don't do the precordial leads, sir, for a babies. They do only the chest.
is it right? How come the outside hospital has done everything?
In our hospital, for no, for most of the babies, they don't have it.
That's inadequate and incomplete investigation, isn't it? Okay, that's your hospital policy. I can't say anything.
What's the classic teaching of a VSD with a large shunt? What a classical ECG finding for a VSD with a large shunt?
So VSD with a large shunt, there will be a left atrial hypertrophy, sir. So there will be a bifid P waves. There will be left ventricular hypertrophy pattern in the chest, in the lateral
ECG,
veins.
in ECG, the correct term is not hypertrophy.
Left atrial and left ventricular strain pattern. Strain
Left,
pattern will be.
that's it. I'm saying the ECG, the expression is left atrial enlargement.
Yes, sir.
Okay, and the ventricle usually is a hypertrophy. In a left, it's you always use a LAE, left atrial enlargement. Then volume overload of the left ventricle because of the large shunt is overload of the left side of the heart. So ECG left atrial enlargement. Most important, left ventricular overload. Unless you take the chest leads, the V5, V6, that's a classical thing where there's a volume overload you have to do. What's the classical thing of a left ventricular volume overload in ECG?
Presence of QS in the lateral leads, sir, and
Yeah,
presence of QS
in
in 2,
V5.
3 AVS.
Yeah. So it's a right axis deviation, except
Yes.
it cannot affect the left axis deviation. Left ventricular hypertrophy.
Yes, sir.
Left
Or a
atrial
biventricular hypertrophy.
and as pulmonary hypertension, it's a
Biventricular hypertrophy.
left plus F. What is the ECG sign of a biventricular hypertrophy?
In a biventricular hypertrophy, there is early transition of R wave in V2, sir. If it occurs, the R wave becomes prominent before V2, sir. In V2, sir. And there is biphasic biphasic
That's the
QRS
answer.
static in V4 to V3 to V6.
Yeah. So not early. Early transition in pathology between V1 and V2. This is not that. This is a biphasic V3, V2, V3. Okay, all right. I don't know why they don't take chest leads. I mean, you think sedation is dangerous? That's fantastic anesthesia environment. Okay, all right. If that's a hospital policy, Aya Krishna, we can't say anything to do that. But I'll say it's incomplete.
This is a well-calibrated ECG at 25 mm per second, with heart rate of 121 beats per minute, sinus rhythm, with the bifid P waves with right axis deviation, with V1 showing RSR pattern, probably right bundle branch block. V2, V2, V3, V2 to V4, V5 has biphasic QRS complexes, indicating a biventricular hypertrophy.
Yeah.
And there are prominent Q waves in 2, 3, and AVF leads, indicating left ventricular volume overload.
What about V5, V6?
V5, V6, there are no Q waves, sir.
Now what?
So there is biventricular hypertrophy, there is left atrial enlargement, and there is right axis deviation, and with early right bundle branch block. So it could be a large VSD. It's a pulmonary hypertension.
Still very good flow in the left ventricle, left to right. Very good left to right and still present. Okay.
Yes, sir.
So now what do you want?
Further investigate with an echocardiography to locate the size of the VSD, and also to see the type of VSD and multiple, if there are single VSD or a multiple VSD, and also associated if any other anomalies.
Good. Okay.
Impression with STS levocardia, large inlet VSD with subaortic extension, with low velocity left to right shunt, intact interatrial septum, this grade 2 TR, severe PH, confluent branch PS, good biventricular functions. The abdominal situs is solidus, cardiac position is levocardia, systemic venous drainage is normal, pulmonary venous drainage is normal, atrioventricular connection is concordant, ventricular atrial connection is concordant, ventricular loop is D loop. The left atrium is dilated, right atrium is normal. Mitral valve annulusis of 15 mm and tricuspid annulusis of 21 mm. Left ventricle is dilated, right ventricle is normal. Intraventricular septum, large inlet VSD with symbiotic extension, low velocity left to right shunt, intact intraatrial septum. Aortic vein annulus is of 12 mm, tri-leaflet, pulmonary valve is of 14 mm. Aorta is normal, pulmonary artery, confluent branch PS with RPA of 9 mm and LPA of 8.5 mm. Arch is left, pedia is absent, normal coronaries. There's mild MR, no AR or AS, grade 2 TR, and normal pulmonary one, pulmonary. The left ventricular LVID is 28, LVIDS in systole is 16, whereas LVEF is 75, IVSD is 6, end-diastolic volume is 31, end systolic volume is of 8 ml.
So what does all this mean? It's operable or it needs cardiac catheterization? If there's a questionable operability in echo, you might suggest it. But in this case, what are you going to do? You think you can straight away operate or?
So there is severe PH, but there is it does not mention how much is the pulmonary artery hypertension.
Yeah,
If it is, yeah, if it is, and we have to see for the pulmonary vascular resistance. If it is less than 7, then it is an operable case. If it is more than 8.5, it is not an operable case. It is an irreversible pulmonary hypertension.
No. Your numbers are not right. For ASD it is 7, for VSD it is 10, and for PDA it is 15. So VSD does accept a little higher PVR, and PDA will accept a much more higher PVR as compared to ASDs. What are the pH now? As you said, I forgot. I didn't catch it.
Outside
Huh?
it is mentioned.
See, that's why when you say
if it is
after
more than
ECG, you should say, I want an echo and Doppler, because only Doppler will be able to give you the figures of a pulmonary hypertension. How do you find out pulmonary hypertension from Doppler, echo Doppler?
Right ventricular systolic pressures plus
Uh,
the gradients across the VSD plus the systolic pressure.
we used to teach them according to TR jet. Have you heard of the TR jet? To assess the pulmonary hypertension.
Yes, sir.
That's how we decide.
A few things in echo you should know. One is assessment of valve area, and the second thing is estimation of pulmonary artery hypertension. And then the third thing is to know the left ventricular function, systolic and diastolic dysfunction. Okay, these things that you should know at the at the tip of your tongue. Please go back and read all these things and make a note. Any other measurements that are important, especially when there is a VSD associated with other defects? Things which can be closed by a patch, things which requires a tunnel. What are the measurements?
Pulmonary
Yeah.
artery.
No, it's the distance between the tricuspid annulus and the pulmonary artery. So that is one measurement you should know. Then the other thing is the LA aorta ratio, which will tell you the amount of shunt. Just like X-ray and ECG, you should also know how to interpret the echo. So please read about the book. There are a lot of articles. There's a good article. I don't remember the exact reference, but surgical this thing for the surgeons, echocardiography for the surgeons. I have it in somewhere. Next time I can tell you where it is available, or I'll forward it to you into your drive so that you can read that.
You do some subcostal view to find out the fourth chamber view to find out exactly where the VSD is, the size of the and the site of VSD. If the VSD is paratricuspid, that's usually AV canal type of defect. If it is subaortic, it's usually a perimembranous type of VSD. If it is subpulmonic, it is an outlet type of VSD. So from that four-chamber view, you can find out where exactly the VSD is situated. Whether it's a canal type of VSD, there's a usual perimembranous VSD, or whether it's a subpulmonic or infundibular septal defect. So what are you going to do in this case?
Subpulmonic VSD is also called what?
Infundibular VSD or outlet VSD.
Yeah. Olden terminology used to be
Supracrystal.
but
Supracrystal.
nowadays that's not used very much. The American terminology used to be supracrystal one part. But I think the European thing has changed now into infundibular septal. So what are you going to do?
We'll go to the final year, sir, for these questions.
Yeah, okay.
Who are all there? I see Logeshwaran. Then who else? Suganya is not there. Amulya is there. And Suganya. Only three of you, no? Okay, Logeshwaran. What will you do with this patient? Is there? Is he
Doubt.
there?
Can you hear me, sir?
Yeah, okay. There are a few students from MIOT. You also can take part. Okay. You can ask questions. You can answer questions whichever whenever we ask you. So please feel free.
Okay, sir.
Any of you going exam going?
Oh.
No, none of you are exam going. Okay. Okay. Okay, Logeshwaran.
I would like to offer surgical closure of VSD, sir.
Hmm.
Surgical closure of VSD. So,
Why not device?
device is most probably for only muscular and perimembranous and for
Hmm.
residual VSDs.
Hmm.
More of inlet VSDs and patient already in large failure and also so will prefer surgical closure.
Okay. What approach?
I will do mid-line sternotomy approach through transatrial, sir, through RA approach. So, mid-line sternotomy, after hypernization, aortic and bicual cannulation. And then once ACT is more than 480, we'll go on bypass. Then we'll give cardioplegia, snug the by SPC IVC, then open the RA. We'll examine the anatomy of the VST. Sir.
How do you examine the VST? What do you do?
Usually we'll track the septal leaflet of tricuspid valve to
Yeah. Say it, no. And then you look onto the ventricular septum.
ventricular
The
septum.
ventricular septum, and then see look for the site and size of the VST.
Yes.
Hmm.
And then I'll define the margins.
If it is a muscular VST, you should also include the number of VSTs because muscular VSTs sometimes are multiple. But in these
Yes.
sort of VSTs, they are usually single. So site and size are important. Okay.
So I'll define the margin of the VSD.
Hmm.
And then we'll close with treated pericardial path, atlas pericardial path with 5 or 13 rolling sutures, continuous sutures.
Where will you start and where will you end? Which is the starting point of your continuous suture? When do you change direction? And then where will you end? And where is the bundle in this VST?
It will be in the postero-inferior border.
Hmm.
So to avoid that, I'll be taking some stitch more on the RV side than on the LV side. So to change the direction at
in the
superior
clock,
border.
in the clock, where will you start? At what level will you start the incision? Where will you take forehand stitches? Where will you take backhand stitches? Where will you which is the dangerous areas? Must know because you said you will inspect the margins of the VSD. So you know what all to look for in the margins. This you should know very well. Okay.
Okay. Okay.
Where will you start?
Around
Because
4
you said
o'clock.
because you said continuous suture, I'm asking you this.
Hmm. Start around 4 o'clock, sir. And then I'll ascend up. I reach around 12 o'clock, 11 o'clock position, I will change the direction. I start from below.
You should know everything about the course of the bundle,
Okay.
undivided bundle, up to what point is a vulnerable area, and up to, below, after which point you can take deep stitches. What the most important vulnerable areas when you look from the right area. Up to this point, I have to be careful because the bundle is passing. The bundle passes onto the left ventricular aspect of the ventricular septum in a perimembranous area. Right at all, yet I go. Onto the left hand side of the ventricular septum, not at the apex. At what point it separates and goes beyond which you can take deep sleep.
Till that muscle of Lances is like.
Very good. What are the name of the muscle of Lances? Very good. It's also known as papillary muscle of the corner, used to be called it muscle of Lances. So that area, beyond that, can take sticks. So that's why previously, and you take stitches away from the apex onto the right ventricular aspect because the interventricular septum is thick there. You didn't take through and through because the bundle onto the left hand side of the ventricular septum, you make preferentially on the right ventricular aspect of the septum. That's why previously used to be interrupted projected sutures in that area so that doesn't cut through. And beyond the muscle of Lances, we used to take continuous sutures, so interrupted. And sometimes we used to take all interrupted sutures with projects. That's most of the present day cardiac surgeons do the continuous suture. And usually, this is one step I know. You take a placental suture, start beyond the muscle of Lances and then go up along that on the parietal band and onto the annulus of the aortic valve. You have to be careful because it's under cardioplegia and the cusp, aortic cusp will collapse. From there, you go to infundibular, ventricular infundibular port. Then you come to the annulus of the septal leaflet of the tricuspid valve. There, sometimes you take zigzag switches to that. Okay? That's how we used to do. I do now. So either continuous, or interrupted, or interrupted placental switch on the vulnerable area. Beyond that, continuous. So you can, in your exam, you say what you have done, seen in Narana area. But theoretically, these are the possible.
See, many a time it's a small baby, you're standing opposite side to the surgeon, you don't actually see where he's taking the stitches. So you have to make an extra effort to go bend down and see. The ideal thing is you must ask your surgeon to wear a head camera for a couple of cases and actually understand the anatomy when they are closing the VSD. for different types of VSDs. Please, no, it will be if you do a video like this, a teaching video, it will be good for not only you, for the future batches as well.
Or we used to directly scrub and stand onto the left-hand side or the head end on the left-hand side of the surgeon, so you can exactly see what he's doing and learn like that, If you stand on the opposite side, you can't see anything in a transactional close-up VSD. So scrub, fully scrub and stand onto the left side of the surgeon and see what exactly, and ask him questions. What are you doing? What are the precautions you take to avoid bonding? What's the incidence of complete heart block in the NH?
Less than 1%.
And that's what this is. That's what textbooks say. So what are the other heart blocks?
Other heart blocks are
All mainly that all. Okay.
the right bundle branch block is almost 90% in the transventricular approach and
Very
40 to
good.
50% in the transapial approach.
Even translated more than 50% of them you have
Yes, sir.
right bundle branch block. What other block you know?
Left anterior hemifascicular block can happen.
RBB with LAH, left anterior. How do you diagnose it?
Suppose with ECG preoperatively, if it shows some right axis deviation, so postoperatively the axis will change to left axis.
Very
based on the-
good. Excellent. And now, modern days, what are the indications of trans catheter or device closure of VSD?
Muscular VSD and residual VSDs are the class 1 indications right now, sir.
And
Perimembranous VSD also will be good, but provided the margin is to be 4 or 5 millimeter away from the aortic valve for the perimembrane.
the methods of closure is one. Mainly surgical, used to be transventricular, now mainly transaxial, and the subpulmonic VSD, transpulmonary closure,
Yes.
and then catheter or device closure or hybrid closure. Okay.
Yes.
Then device closure, most of the surgeons think that only mid-muscular VSD is the best one suited for the device closure. An anterior muscular defect may also be closed, may also come as fast one. And most importantly, residual VSD in the lower part of the membrane of the patch is a very good indication, part one indication of closure, because you don't have to reoperate. You can safely, because in the lower part of the patch, it's away from all the bundles. Other three indications of doing a class 1 indication. Class 2A or B is a perimembranous VSD with a margin of more than 4 millimeter below the aortic valve. Then only you can do it as a special diagnosis. And what are the other conditions you have to satisfy before you do a catheter closure, device closure?
There should not be any aortic regurgitation
No,
or any
first,
bundle.
first say about the weight of the kid. What is
Okay.
the recommendation?
Weight should be more than 8 kgs
Yes,
for a
more
VSD.
than 8 cases. That's what the latest I saw. And they say more than 5 kgs in case where mid-muscular, whatever it is actually. All right. One is that.
Shunt should be more than 1.5:1.
Yeah. Shunt. I mean, it should okay. The shunt should be more than 1.5. That's a significant shunt. Yeah.
Yes. And there should not be any aortic regurgitation.
Yes. There should not be a collapse of the any of the
Aortic.
cusp of the aortic valve. There should not be any aortic regurgitation, no SAM, no mitral valve problems and no tricuspid. In this case, I think they have said the VSD is paratricuspid or something they said. So this is not suitable for a device closer. Only needs a surgical.
With conduction blocks also, we won't prefer the device closure.
Yeah. Okay. And this is surgeon, you think there's only limited indication to do a device closure, especially in a perimembranous VSD. And sometimes they do a hybrid closure in a hybrid theater. Do they do that here? I think they've tried few, but I don't know whether they still do the hybrid closure or not.
Sudesh does a review.
So suppose the patient with a VSD, PDA, VSD with coarctation, what's your view? How should we approach? PDA, of course, suppose it's a PDA. There's a large PDA, small VSD, what's your approach?
So initially, we have to address the PDA. So initially, we'll do thoracotomy PDA closure and wait for the small VSD to close, follow up the small
So the
VSD.
small VSD may close by itself. So usually you do large PDA from the left side thoracotomy and leave it in. But in post-operatively, if you find that the VSD is much bigger than we estimated, you can always do a mid-sterotomy. I think Colin Johnson used to do a left thoracotomy and turn and do that. Most people don't do. They observe in the post-operative period, and if necessary, you can do. Suppose it's a coarctation. Logation, tell me the answer. Very significant coarctation with small VSD. The classical approach is to do the coarctation first and wait, as in the PD is what happens to the VSD when they're going to close themselves or not. And significant coarctation with a moderate size VSD. Previously, in our time, we used to say that such cases should do coarctation first at the same time do a PA banding. But that's given up. Most people don't do PA banding because of the problem.
Yes.
And if it's a very small infant, there's significant coarctation and a big large VSD. Nowadays, most pediatric cardiac surgeons do on the pump from median stenotomy tackle both coarctation and VSD at the same time. That's a classical approach. Okay.
Any other questions?
What are the indications of pulmonary artery banding in case of VSD?
Swiss cheese VSD.
Huh?
Swiss cheese VSD is a multiple VSD, Swiss cheese type of VSD.
Don't just stop with multiple VSD. In this hospital, multiple VSDs are operated. In a
Okay.
small infant with multiple VSD.
Okay.
Okay, all right. Small infant with multiple. Then very large VSD, almost equivalent to a univentricular heart or a single ventricle, where you cannot do a two ventricle correction at the later stage. Such cases for palliation, you do a pulmonary artery banding, and then later on you do Fontan. BDG and later followed by a Fontaine operation. Number two, that's indication for banding.
Amulya here, sir. Sorry, sir. We actually had a case taken in, then I had to go there, and then I told I'll come later because they were starting.
Okay.
Go.
Okay.
Uh,
So,
Indication PGA with intact ventricular septum in case of rapid correction, rapid two-stage. It is followed as PA band.
excellent, very good. In a transposition, a simple transposition, that means which doesn't have VSD, which come later on, because the ideal time to do a correction in simple transposition is 3 weeks. Beyond the 3 weeks, the left ventricle, which going to be the systemic ventricle is aggressive, so much shorter. So that used to be for a rapid two-stage switch, where you do a pulmonary artery banding with or without a PT shunt, depending on the saturation at the end of the band. And within 1 week, we do echocardiogram every day and see whether the systemic ventricle has hypertrophied enough, then you can do a switch. So as a, when the Indian cardiology say less than 2.5, which I don't agree very much, because to do a banding in a kid less than 2.5 is more difficult to get the correct size. And the other thing they mentioned is that a child who has got respiratory infection, if the respiratory infection is there, which at the time needs urgent surgery, it's better to avoid cardiopulmonary bypass. These are the 4 indications given in that paper. So you read it again and then you know. Okay. I'm very glad you answered that rapid two-stage switch, which nowadays we don't do that. Why? Nowadays, I think they stopped doing that. Nowadays, that's been replaced by ECMO. If a baby with a simple transposition comes beyond 4 weeks, you see, nowadays, all the smart cardiac surgeons say you can still do it and put the child on ECMO till the ventricle hypertrophies and become maybe able to pump into the systemic circulation. So many people don't do a rapid two-stage switch. Any question? It's not that. Any questions?
So VSD here, perimembranous VSD closures, most of them, what I've seen is they start inferiorly with some surgeons take horizontal mattress and then ascend inferior along the inferior border, keeping about 5 mm away from the inferior margin, ascend up, and then the gonal septum, the aortic valve annulus, to make sure that it does not include the coronary cusp, and then ventricular infundibular fold, they stop there, and then the posteriorly they cover along the posterior border, and then at the tricuspid the septal leaflet along the atrial surface they put a pledget and then tie it off. So, keeping most of the sutures as possible forehand where it is not possible, and then once done, uh, interrupted sutures are taken if at all there's a wide spacing or any dog.
Whatever it is, when you come to the septal leaflet attachment, you take a zigzag suture. If you're coming down or you coming from above, from the ventricular infundibular fold, you take the stitch from the ventricular side through the annulus into the atrial side, and then go back across the annulus onto the patch, like that go zigzag, that's what many people, or you can put interrupted sutures there. But most people do continuous zigzag sutures. Coming from the patch to the atrial aspect, and from the atrial aspect back to the patch, like that thing.
Yes.
Stick to one method, whatever you see, what's acceptable to you. You mentioned that actually, instead of getting confused. So what you have seen in this hospital, that's what you mentioned. Don't say this surgeon does that, that surgeon does this. So that's not, in an exam you can't say that. So whatever you've seen from different surgeons, you accept one as the whatever it is, and then you stick on to that method.
Yes.
The basic surgical technique is if you're taking a stitch towards you, it is always forehand. If you're taking a stitch away from you, it is backhand. So from maybe 2 or 3 o'clock position to say 10 o'clock, you can go forehand. And when you go away from you between 2 and 10, it is usually taken backhand. Okay.
Yes, sir.
Similarly, anywhere in the surgical technique, if you are taking a stitch towards you, it is forehand. If you're taking a stitch away from you, it is backhand. Like similarly, when you're taking a stitch on the sternum to around the wires, it is usually backhand away from you, but towards you, it is forehand. So that is the basic surgical technique you should know. Anybody else?
What are the indications of a left ventriculotomy or closure of a VSD? Can't hear.
A BSR, ventricular
Yeah.
septum.
Acute myocardial infarction, ventricular septal rupture, the approach is always to the left ventricle over the infarcted part. And then previously, we used to say a Swiss cheese effect, the approach is left ventricular. Nowadays, people don't do that. Why do they say in a Swiss cheese defect, the approach should be left ventricular? What's the reason?
Because the trabeculated side from the RV, it is difficult to find.
Yeah, very good. Because the left ventricular septum, it's not trabeculated. So very often in a Swiss defect, it's a single defect in the left ventricular aspect of the septum, whereas because the right ventricular aspect is trabeculated, it comes many multiple, you can't see where exactly it is. So that's why in textbooks they used to say that many people don't know nowadays. Yeah. Many crosstalk.
Okay.
Transpulmonary is another. Okay, all right. That's enough today.
I think it's 8:55. We'll
Yeah.
stop. Thank you.
Sure.
Thank you,
Sure.
sir.
Thank you very much. Thank you.
Thank you.